Hello, everyone. I'm going to be talking today about long-acting injectable antipsychotics in this particular case. There are other long-acting injectable medications, of course, such as naltrexone, but this is going to be focused mostly on, it's going to be focused entirely on antipsychotics. I'm Andrew Penn, as you know, and these are going to be our learning objectives, really to understand why we would think about using a long-acting injectable, to understand what drugs are out there and available, and then how to make a transition from an oral medication to an injected medication. I think it's fairly self-evident, but it's worth thinking about what happens when people stop taking medications. And we know that people, particularly those with schizophrenia spectrum illnesses, are commonly non-adherent to medications. Up to three-quarters of people with schizophrenia spectrum illnesses are non-adherent to their medication regimens. And what we know is that this tends to predict relapse. So, about half of the people who stop medications will have a relapse of their illness, usually fairly quickly within a few months. And that we know that the non-adherence really predicts relapse, whereas when people stay on medications, it doesn't totally predict them from relapse, but it definitely significantly improves their chances of staying well. And this is a really important argument for staying on medications. But it's also worth considering, though, that this is not a problem that is unique to psychiatry, that most people, many of you come from a primary care background, and you know that your patients, whether they have schizophrenia or hypertension or diabetes, many of them don't stay on medications. And then about half of people who are dealing with a long-term medical illness choose not to take medications. So shouldn't be surprising that people with mental illnesses also often have the same problem. So, we see this across different disease states, even things that you would expect would have a high rate of adherence, such as anti-rejection medications. A fifth of people will not be adherent with their anti-rejection medications. So it's not just psych. And there's a lot of reasons why people don't take medications. Of course, there is this notion, this idea of anosonia, which is one of those fancy psychiatry words, which means that you aren't aware that there's something wrong with you, and that if you don't feel like anything's wrong with you, why would you take medication for this? We also know that a lot of our medications have considerable side effects, which have often left people feeling really negative about their medications. And we also should be thinking about what impression are we making on that patient about medication treatment each time we prescribe. Because if somebody comes in, say, to the emergency psychiatric room and they're given medications that make them feel horrible, should we be surprised when they don't want to take medications upon discharge? I don't think so. So we need to make the experience of medications as positive as we can if we want to think about this person continuing to take medication down the road. Of course, there are other aspects of psychiatric illness or the things that are associated with psychiatric illness, such as substance use and the cognitive impairment that can come with something like schizophrenia, which often makes it difficult for people to even remember to take medications. And if you've ever had a hassle with pharmacy, to getting something approved or getting something uh, filled, you can see how easy it is to just kind of give up on that, especially for people that don't have the financial resources, the support resources, and even just practical issues like getting to a pharmacy on time. And then we have the whole issue around stigma and how these illnesses are often things that are stigmatized. And so it's understandable that somebody with all these other associated problems might just say, well, there's nothing wrong with me. Why do I need to take medication? So we shouldn't be particularly surprised. And, we throw on just as a final thing in there that many of these medications don't work as well as we would like. If they worked robustly well, then perhaps people would be more interested in taking them. But since they often cause, as many side effects as they do benefits, and sometimes even more side effects than benefits, you can see why people might be apprehensive to take these medications. So we also know that, each time somebody gets sick, it makes them often more unable to function in their day-to-day life. We know that these relapses often sometimes are associated with suicide attempts. And what it often ends up happening is we end up waiting to use long-acting injectable medications. We often wait until the illness is quite severe or there's been this sort of history of medication non-adherence. And the thing is that increasingly we're seeing recommendations from organizations like the American Psychiatric Association suggesting that patients be offered long-acting injectables, especially if that's something they're interested in or if they have been uh, intermittently adherent. And the reason for that is that, we see a decrease in hospitalizations, uh, we see people stopping medication less frequently if they're on long-acting injectables, what we call all-cause discontinuation, which means, people that stopped it because of the cost, people that stopped it because of side effects, people that stopped it because they couldn't get the medications. Like all those causes are reduced when we use long-acting injectable medications. And I think about just a very simple thing that a patient said to me once years ago, who I had on, I think in Vega, and which is a monthly paliperidone injection. And he said, with oral medications, I have to decide to take them every day, but with the shot, I only have to make one decision a month. And that's always stayed with me, that sort of dilemma that people have every morning as they're looking, or every night as they're looking at their pills and deciding, do I want to be a part of this? And the idea is by sort of reducing that decisional burden, then we're more likely to keep people on medications. Now, I want to kind of get ahead of some of the confusion. I often find that these drug names are quite confusing. And, there's something like, oh gosh, 10, 11, 12 long-acting injectable medications out there. But take a look at this. They all are kind of in the same grouping. So we can think of the two that are kind of the classics. So, we got haloperidol, Haldol, and fluphenazine, which is Prolixin. Those are the old what they call decanoate shots. We'll talk about that in a minute. And then really we've got there's risperidones. And if you remember, paliperidone is just the metabolite of risperidone. So we can kind of chunk those two together. And then we have aripiprazoles. And then we have olanzapine, which is a little bit of an outlier, and I'll explain why. But really, we have all these different brand names that point out these different formulations of these. But really, it's kind of the old school, the risperidone, paliperidones, the aripiprazoles. And we got the outlier of olanzapine. So don't let this throw you off too much. You may remember this meme from the ADHD week, and really, remembering that these are all kind of variations on this theme. So don't get too confused by all the different names. And I'm going to break my own rule that I said at the beginning of the class, or, my guidance. I said, please use generic names for the most part, because these are generic medications that have been reformulated into these long-acting formulations, and each one is a little bit different. I'm going to use the brand names for clarity, which I don't normally do, but I think it's useful here. So really, long-acting injectables are all about pharmacokinetics. It's the same drugs that we know about from our dopamine or dopamine serotonin blocking module, right? So it's doing the same thing at the receptor that an oral medication does, but what we're playing around here with is the pharmacokinetics. So if we take a look at this blue line on this chart, you see this is the difference, the delta, if you will, between the peak and the trough of those drug levels. Pretty significant. And you see each day, it goes up and down, right? Whereas that orange line is this kind of smooth, slow up and down of a long-acting injectable. And so the downside to that up and down that jagged line is that we have more side effects when the drug serum levels are higher, and we have potential for more breakthrough symptoms when the serum levels are lower. So by keeping that more consistent, we see less of that sort of jaggedness and more smoothness and longer duration of effect of the drug. And you heard me use this term earlier. Well, I used decanoate. I'm going to talk about depot injections. And so this, sometimes you'll run into an old school psych person like me, and we'll refer to them as depot injections. So when you think about a depot, like a depository, right? So the thing with the long-acting injectables is that the amount of the drug that is in the body has really more to do with how much is deposited and how quickly that drug is absorbed. Typically, when we think about drug levels, we think about elimination as being the determining factor of how long the drug is in the body. But in this case, we have this what sometimes referred to as it's flip-flopped. So it's flipped from oral drug kinetics, where in an oral drug kinetic, you take the drug, it's absorbed, and then how long it stays in your body is really a function of how quickly your body metabolizes it and excretes the drug. Whereas in this case, we inject the drug stays in the body, and how quickly it's absorbed is really what will determine the drug levels. So this is that flip-flop kinetics. So you can see this put differently on this chart here, that with the oral drugs, we see this quick absorption, and then the elimination rate tells you how long the drug's going to stay in. Whereas the long-acting injectable is deposited, that depot is referred to sometimes, and how quickly it's kind of taken up inside the body, and as it becomes an active drug will really determine the drug levels. So the pros and cons of these things, obviously with things that we've already talked about, you know if the person took it because they showed up for their shot, it gets rid of that oral medication problem. They're not able to overdose on it because it's not in their control. You have that smoother uptake and less of that jaggedness. And also we see patients on a regular basis when we give these LAIs. So we have a chance to kind of check in with them. And I've seen clinics that really will kind of leverage that and create, perhaps a group on the day that they come for their shot, or a case management visit, or getting labs done, or seeing primary care. You have a person there, you might as well take advantage of it. Now, the downsides is that they're expensive, and we'll talk about that in a moment. And it does take longer for these drugs to kind of get up and running, which is why it's often easier to substitute a long-acting injectable drug for a oral medication that the drug is already taking. The other downside to these things is that they are a commitment. So if the person isn't tolerating the med, they're stuck with it until the end of that duration of that injectable. So, if the this can be a real problem because we obviously can't take the drug out once it's in. And so you really need to make sure that the person is tolerating the med with oral medications before we switch to a long-acting injectable. Also, there's the logistics. The person, there needs to be an injection clinic or somebody, or you can give the injection. Sometimes I see happening. And the other challenge is that a lot of these drugs have these sort of fixed increments, and it's often difficult to make smaller adjustments. So we're making kind of big clicks, if you will, in changes, and that's sort of a challenge. And then, of course, there's that some people just don't like shots; they hurt. Particularly the older decanoate ones are in a sesame oil, which I'll talk about in a moment. It's pretty thick, and it can be kind of painful. So the cost of these meds is substantial. So if we take a look at this, you're seeing for the newer medications ranging anywhere between sort of 15 to $75,000 a year. The average being somewhere around 28 to 35,000 a year. And obviously, these are a lot more expensive than some of the oral medications. We can get risperidone for really just a few dollars a month now. Aripiprazole as well. These branded medications. So these, with the exception of haloperidol and fluphenazine, do not come in generic depot forms, and so they are expensive. But then we have to look at, well, what is the cost of non-adherence, right? And so the interesting study that was done, looking at about 2,000 people, looking at their costs before they went on a long-acting injectable and then afterwards. And what's interesting, if you take a look at that red box, so their all-cause total medical costs went down significantly after being on the LAI. And even when we look at things like inpatient hospital admissions, those go down significantly. The length of stay gets cut by over half, and the costs go down by over 50%. Now, the drug costs, as you can see at the bottom here, do approximately double, a little more than double. So that does reflect the sort of shifting of costs from maybe sort of resources in the form of hospital stays and shifts them into to drug costs. So pros cons, obviously this is going to vary from patient to patient depending on what sort of coverage they have. So let's get into the individual drugs. So let's talk about haloperidol decanoate, and we'll talk about the kinetics here. So decanoate refers to this decanoic acid ester, which is attached to the haloperidol drug molecule in this oil base. It's literally sesame oil. So it's a kind of thick, viscous injection. It really you have to push it pretty hard through the needle, and it's can be painful in larger doses. So typically, it's like 100 milligrams per ml. So when we get into bigger doses, like needing 3 mLs, those tend to be kind of painful. Now the dose is going to vary. So 25 to 450 milligrams every 4 weeks is the duration effect of this drug, and it's an intramuscular into the gluteus muscle. So you got to give it in their butt. Uh, the it takes so the half-life is about 21 days, which is why we can get about 30 days of effective benefit from the drug. And it takes several days for the drug to hit its maximum absorption once it's been injected, and it takes several. Remember that old rule of pharmacokinetics that it takes 5 half-lives for a drug to come to steady state. So if the drug half-life is 21, so 21 times 5 is about 100 days. So somewhere a little north of 3 months for this to get to steady state. And of course, Haldol is a D2 agonist, and then it is metabolized by 2D6. So how do we make this conversion? So let's say the person is taking 10 milligrams of oral haloperidol. We're going to take that daily amount and multiply it by 20. So that's going to give us a dose of 200 milligrams a month. So 100 milligrams per milliliter, that's going to be 2 mLs. And for loading this, we're going to divide this. So if we're just making this conversion, we're going to give a smaller dose for the first time, and then 14 days later, we're going to give the other half. So 100 milligrams at first, and then 14 days later, we're going to give another 100 milligrams. And then going forward, we can just give that 200 milligrams after every 4 weeks. And we can start coming off the oral medications after about 2 or 3 injections, right about the time that the Haldol decanoate is getting to steady state. We can start bringing down the oral medications, the oral haloperidol. Excuse me, I got a bit of a runny nose here. Let's shift to the other option in first generation antipsychotics, which would be fluphenazine. This is known as Perlixin, also a decanoate, same technology, this decanoic acid ester, sesame oil. It's a good alternative to haloperidol. You will see older patients with schizophrenia who have been on this medication for 20, 30 years. It's not uncommon. And, when I first started in psychiatry, I thought, why would anybody want to be on these old school antipsychotics? And, a lot of times they'll tell you, I was, I had a psychiatrist who put me on these new medications when they first came out. They really just didn't work as well as the old ones. So I'd rather just stay on the old ones. It's what I know. So fluphenazine, Prolixin is definitely one of those old school meds that some people just really like, and it works really well for them. And I'm kind of the school of thought, if it ain't broke, don't fix it, because it takes a while to clean these things up if they get messy. So, I tend to lean towards sticking with what's working. With this drug, we're looking at doses of about 12 and a half to 100 milligrams every 2 to 6 weeks. It can be given in the deltoid or the gluteus muscle. The Tmax is pretty quick. This is a shorter acting drug, obviously. Half-life is about 14 days, which is why we're doing this sort of about usually every 2 to 3 to 4 weeks. And that's going to be driven by sort of clinical response. So if somebody after, say, 2 weeks is starting to have more auditory hallucinations or paranoia, we might increase the dose or we might do it a little more frequently. It does take some time to get to steady state, a little less time than haloperidol. This is a drug that is metabolized largely by 2D6. So we want to think about that if we're giving a 2D6 inhibitor, like something like paroxetine, for example, or bupropion, strong 2D6 inhibitors that might raise the levels of prolixin. So the conversion here is we're going to take the oral dose and we're going to multiply it by 1.25. So in the case of, say, a patient taking 5 milligrams of oral flufenazine a day, we're going to convert that, multiply it by 1.25, which gives us 6.25 milligrams every 3 weeks. For the loading dose of this, so while we're doing this, we're going to go ahead and give that injection, and we're going to give half of the usual oral dose for those first 2 weeks. And then we can stop that after the second dose of the injectable medication. We can also do an IM loading dose here. So you could take, say, 1.6 times of so say a patient's taking 10 milligrams of flufenazine orally, you could give them 16 milligrams of IM weekly for every 4 to 6 weeks. So that's another way that you can make that conversion. Okay. Let's switch now to the second generation antipsychotics. So we'll first start talking about the risperidones. I like it. That sounds like a boy band or something. So this would be this. This was the first second generation antipsychotic, long acting injectable. So risperidone Consta came out, oh gosh, over 20 years ago now. Fairly short acting it's a short acting, long acting injectable. How's that for an oxymoron? It's given every 2 weeks, and has indications, FDA indications for schizophrenia, bipolar monotherapy, or bipolar one treatment with valproate or lithium. It only lasts for 2 weeks. We'll get a little more into the details in a minute. Perseris, sorry, was just discontinued recently, so I'm not going to get into that. Raikindo, I told you this sounded like boy bands. Raikindo is a newer kind of kid on the block. This is intramuscular. It also is every 2 weeks. So it is also another formulation of risperidone. Has the same indications that Consta has. So schizophrenia and bipolar disorder. And then Uzedy is a sub-Q medication. So that's more appealing to some people. It doesn't require the deep gluteal or deltoid injection. Its indication is for schizophrenia, and it can be given every 4 to 8 weeks. So here's your kinetics. So all of these, take multiple days to get to full absorption and maximum serum concentration. So we're looking at sort of anywhere between 1 to 3 weeks for that to happen, and then the half-life typically in the order of at least a week, if not longer. So it takes many weeks for these to get to steady state. And remember, the same pharmacokinetic interactions apply here as they did to just plain old oral risperidone. So 2D6 inhibitors, because risperidone is cleared through 2D6, is going to increase the levels of risperidone. Obviously, 2D6 things that activate 2D6 would decrease it. 3A4 being the other pathway through which it's cleared. So things that are going to induce 3A4, like carbamazepine, are going to reduce risperidone levels, and you might need to make clinical adjustments. There is the possibility of using serum levels to measure this, but that's a more advanced skill. It is sometimes talked about in the prescribing information, which I'm going to encourage you to take a look at. And I've put links to all the different prescribing informations in Canvas. So you can go ahead and click through those because those are going to be your friend for working with these different agents. So going from an oral risperidone to a long-acting version of risperidone, obviously we're making sure that the patient can tolerate risperidone before we commit them to a long-acting drug, right? So the typical conversion there, if you're taking 2 milligrams a day of risperidone orally, that's going to be about 25 milligrams of risperidone consta, and you're going to give oral risperidone for 3 weeks while you're starting that consta injection. with its buddy Reikindo. This is also 25 milligrams in the glute intramuscularly every 2 weeks. But this one you only need to give risperidone for 1 week while you're starting the injectable Reikindo risperidone. And with Uzedy, 1 milligram of risperidone is equivalent to about 25 milligrams of Uzedy subcutaneous, which can be given in the arm or in the belly. And it does not need you to continue with that oral risperidone, which is kind of the advantage to this new kid on the block, Uzedy. Then we have the paliperidone. So, if risperidone was the original Backstreet Boys, paliperidones are sort of the knockoff band, right? So, remember, paliperidone is essentially the first metabolite of risperidone. So they are very related. And these are known as Invega. So the brand name for these are Invega. Um, like a lot of these things, they have pretty cutesy names. So Sustenna is the 1 month, every 1 month treatment, which is indicated for schizophrenia. That's an intramuscular drug. Trinza, as you might imagine, is wait, Trinza sounds like try, which sounds like three. Good marketing because it's given every 3 months intramuscularly for schizophrenia. And possibly my favorite branding uh, twist ever, Invega Hafira. I bet you figured it out. It's good for 6 months, right? Half a year. And this is also intramuscular and indicated for schizophrenia. So the dose range on Sustenna is quite broad. We've got between 39 and 234 milligrams every 4 weeks. So this is a monthly drug. Takes about half that time to get to uh, full serum levels. And then the half-life is long. So, this is why we're able to do these things so infrequently. And it takes several weeks for this to get to steady state. Similar drug-drug interactions that we're going to think about with risperidone, we're going to think about with paliperidone. So 2D6 inhibition is going to cause paliperidone to go up. 3A4 induction is going to cause paliperidone to go down. Trinza, so you're really just kind of seeing the trend here, right? Bigger volume, bigger number of milligrams, given less frequently. So Trinza allows us to do this every 3 months or every 12 weeks. And then half year is every 6 months. And with these, the longer the drug lasts, typically the longer it takes to get to Tmax and the longer the half-life, which all makes sense because remember, this is all about pharmacokinetics. So again, make sure the person can take paliperidone before you commit them to a long-acting version of this. Sustenna, 12 milligrams. You can see this chart over here. 12 milligrams is equivalent to 234 milligrams. If you're on 6 milligrams, you'd use a 117 milligram dose, right? When we're initiating this, we're going to do so let's say the person is on, oh, sorry. If the person is on the 234 milligrams, we're going to give that 1 milligram, sorry, the 234 milligram injection on the first day, and then we're going to give 156 milligrams. Uh, I think that should say 4 weeks later. So this is where these things are complicated, and I would say, really, this is one of these cases where memorization, unless you're doing this every day, is probably not particularly useful. Just have a good drug guide, bookmark those prescribing information, and go and look it up each time. Really, the way this was structured was that the idea was kind of get a customer, keep a customer, and maintain a customer, right? So Sustenna is your starting. Trinza is indicated only for people that have been on Sustenna for 4 months, and then Hafyera allows you to go from the every 3 months of Trinza to just twice a year for the Hafyera. And again, all this sort of data is here. This is all taken verbatim from the prescribing information, so you can see where if the person was say taking 78 milligrams of Sustenna, so this would be the low dose, you would convert them over to 273 milligrams of Invega Trinza. Okay. And again, similar if depending on if they're going from ppm 1 would be Sustenna, so that's once a month. If they're on a lower dose of that, say 156, Sorry, that's not actually a low dose. That's sort of a medium dose. It's the equivalent of 9 milligrams a day. Oral medication, they're going to go to 1,092 milligrams of the every 6 month version. Okay, so again, just get used to looking it up is probably the best thing I can tell you. Don't waste brain power on memorizing all this stuff. It's just going to exhaust you unless you're doing this every day, all day long, working in a psychosis clinic or something like that. Let's move on now to the arapiprazoles. So the arapiprazoles, this you know them as Abilify, but there's three different versions that are available. So there's Abilify Maintena, which is their monthly drug indicated for schizophrenia. This is an IM. These are all IMs. Aristata is interesting because it's aripiprazole, but it's this Loraxil version. So Loraxil is an aripiprazole prodrug. So the way that they've created this is they've created a drug that converts to aripiprazole in the body. So you remember a prodrug is inert by itself, but in the body it converts. So aripiprazole, Loraxil changes to active aripiprazole in the body. And there's a couple different ways of getting this started. I'll talk about that in a moment. But they're IM and they're done every 4 to 8 weeks, indicated for schizophrenia. And then also one of my favorite drug names, Abilify Asimtufii. Um, I think I made some drug reps' eyes roll when I referred to it as asymptoophy. But apparently it's meant to say that it is reducing symptoms and it's done every 2 months. Gotta love drug branding, right? But this is indicated for schizophrenia, as most of them are, but this is also indicated, FDA indicated as a bipolar 1 monotherapy. So the Montana dose range is typically 400 milligrams a month, and it takes about a week to come to maximum serum concentration, and it has a long half-life, as you might expect. So it takes several months for it to get to steady state. Aristata, which is that pro-drug, there's several doses available between 441 and 1,061 milligrams. You can give it in the deltoid, which means that it will get to serum levels faster than if you put it in the glute. I think it just absorbs more slowly from the larger glutamate muscle. Again, long half-life, long steady state. And Abilify Simplify is 960 milligrams every 2 months. And these have the same drug-drug interactions that we would have with any other kind of aripiprazole. So, again, 2D6 is generally how it's cleared. So anything that inhibits that could raise the levels of aripiprazole. Anything that inhibits 3A4 could also increase aripiprazole, and anything that induces 3A4 could cause it to drop. So again, you're going to hear me say this many times tonight. Make sure your patient can tolerate aripiprazole. The last thing you want to be doing is giving somebody a really bad case of akathisia by starting them on a high dose of a long-acting injectable aripiprazole because you didn't see if they could tolerate the oral first. So always make sure that they can tolerate the oral. With Abilify Maintaina, you're going to keep going with the Abilify, the oral Abilify for 14 days after you start the injection. Aristata, as I mentioned, is a little bit complicated because they have a product called Aristata Initio, which is a 675 milligram dose of Aristata, which is given with one 30 milligram dose of oral aripiprazole. So they get those two things together, and they get the Aristata injection. So there's a lot of things going on there. The other way you can do it is that you can give a first dose of Aristata, like say 440 milligrams. Sorry, not 440 milligrams. Yeah, 441 milligrams. So let's say the person is taking 10 milligrams of aripiprazole every day. They're like, I want to go to an injectable medication. What you could do is you could go ahead and give them 441 milligrams injected of Aristata, and they would then continue for the first 3 weeks after that injection on their 10 milligrams a day. So they're going to take the two together because remember that Aristata injection is going to take some time to be absorbed. And you want to have the aripiprazole drug available to do its thing, so it's preventing symptoms that you are treating. And then Abilify Asymptophy, Asymptophy, sorry, I'm now laughing at my own jokes. 960 milligrams every 2 months, and you would continue the oral Abilify for 2 weeks afterwards. Then we have our little outlier, so olanzapine. Now, remember, this is not the same thing as intramuscular olanzapine that is immediately acting that you might have seen used in a psych emergency room. This is their long-acting injectable. It hasn't really gotten a lot of traction for reasons that I think will become clear in a moment, but this is IM. It's given every 2 to 4 weeks, and it has an indication for schizophrenia. The dosing goes from 150 to 405 milligrams. Like all of them, it takes some time to get up to therapeutic levels and steady state. Um, but here's the problem with this stuff. It has black box warning because you have to keep the patient there for 3 hours after you give the injection because there's this post-injection delirium syndrome that can happen. And of course, you would never give this to somebody unless you knew that olanzapine was tolerable and ideally effective for them, which is why you would be going to all this trouble. And here's your conversions, right? So 10 milligrams of oral Zyprexa a day is going to convert over to 210 milligrams for the first couple of weeks. And then going forward, after 8 weeks of that, you're going to go, so you go 210 for 2 weeks, right? For 4 times. And then you're going to 150 milligrams going forward after 8 weeks. See why I told you not to memorize this stuff? It's just too nuanced. And as long as you can get onto the internet and pull up these prescribing information, which is exactly where these screenshots were taken from, you can get this information and remind yourself because don't waste your brain power remembering things that you can look up easily. So there are some things I didn't go over today, but just in the interest of time, and but to point out where you can get this stuff, the prescribing information, that same document that I had you look up in the first week to figure out where drugs were metabolized and their kinetics and all that stuff. You can find that all for free on the FDA website. Simply just Google something like Aristata prescribing information, and it'll take you right there. Don't get distracted by the sponsored things on the top. Just look for the FDA or the drug manufacturer's uh, website, and that will take you to that, thing that's in 4-point type with lots of information, but lots of really valuable information. So it will also tell you how to prepare and administer the drug, because a lot of times these things need to be shaken in a particular way or reconstituted. Their storage often is important. Sometimes they're shelf stable. I'll tell you back in the early days with Consta needs to be refrigerated. And even back then, it was like $2,000 a vial. And the pharmacy would sometimes drop it off at the clinic I worked at and not tell us that there was something that needed to go in the fridge. It would sit out on the counter for 4 or 5 hours. It would go bad, and we just wasted $2,000. So it's important to know how to put these drugs together. Like there's certain things that need to be reconstituted. There's often certain needles that need to be used because of the thickness or not of the drugs. Length of the needle is going to be important. So obviously, injection technique is going to be important. This is where nurses, I think, really shine because even if you haven't given an injection in a long time, like me, you can learn. It comes back to you, right? It's like riding a bike. So this is something we can offer in clinic and just in a system where this is supported. We can prescribe it and administer it and get it done. But we got to know these things here. Also, things like what to do about missed doses. If you have to, not surprisingly, sometimes people will fall behind in their schedule, and then you got to know what to do to bring them up to speed. That's all in the drug prescribing information. And also, sometimes there's content in there about what plasma levels we would look for. It's not common that we look for plasma levels with these drugs, but probably the antipsychotic, which does not come in a long-acting injectable that we do use serum levels sometimes is Clozaril. talked about that in a previous lecture, but typically we're not doing serum levels with these things. We're looking clinically. If somebody is, at the end of their dosing window, like I'm thinking of my guy who said, I only have to remember to do this every month. He was on a once a month injection that would start to wear off at about the third week. So we moved it up a little bit. We had him coming in about every 3 to 3.5 weeks was his frequency. So you'll need to make those little bit of clinical pivots because pro tip, because of the cost of these medications, it's often very difficult to do these off label. The good news is because of the burden of schizophrenia on the mental health system, a number of these drugs are covered by things like Medicaid and Medicare, even though they're very expensive. But you're going to have a really hard time getting these things approved for off-label uses. So that's why it's really important to make sure that the indication for the drug matches the patient's diagnosis, because that's going to make getting approval a lot easier. But again, when you can't remember what the heck I said about these meds, you can go back to these notes for reference. But really, I'm going to want you to get familiar with going back to the prescribing information. So with that, I hope this is helpful. We'll try and have some. Perhaps we can do some exercises to play with this information and start to get a little more familiar with it. But I hope this has been a little less intimidating than this topic can sometimes be. And I'll see you later. Thanks. Bye.